it's, as rightly pointed out, it's like a very hot topic to discuss right now. How low can LDL go? And the slides, please. Yeah, thank you. So before let's jumping right into how low can the LDL go, let's just, it's not the proverbial villain that LDL is always painted as, but it has a lot of physiological roles. We know it's an important component of cell membranes. It's required for origin of many steroid hormones, and it is and a lot of other important transport of important stuff. So again, cholesterol can be both exogenous and endogenous in origin, and of this all basket of lipid molecules that goes around the body, LDL constitutes around 90% of those molecules, and it is regulated extensively by the peripheral cells, liver cells, as we have seen. Despite, we all know the interplay between HDL and non-HDL cholesterol, this slide just wants to highlight, despite having the same number of HDL and non-HDL, still in all plethora of patients that you will see, LDL will still contribute to the maximum amount of the lipid load that's going to be there for a particular patient, and that is why it is so important for atherogenic properties. We know the metabolism, around 20 to 30% comes in from the dietary exogenous pathway, and around 70 to 80 through endogenous origin in the liver. And this is a chart that we all probably memorize in our med school. So how, there is, given that we discussed that LDL is very important, how effective or how safe is it to actually reduce it to almost very low levels? So there have been proofs in nature. Neonates have very low LDL levels at birth, and this is at the time when body is actually supporting a lot of organ formations. There are many hunter-gathering societies who exhibit lifelong LDL levels of less than 50 and still no associated health risk. There are genetic variants where there is a loss of function of PCSK9. Again, LDL levels remain extremely low, almost to the range of less than 15 milligram per deciliter, still without any major adverse events and having a low atherosclerotic disease risk throughout their life. So the key benefit, again, as we rightly know, is the coronary atherosclerotic disease plaque progression. That will translate into reduction in cardiovascular death, myocardial infarction, coronary revascularization, and angina. The concerns with extremely low LDL is there are speculations about new onset diabetes, hemorrhagic stroke, cataract, and also a lot is talked about an impairment in the neurocognitive function. But there have been no statistical proof, and we will see in the forthcoming slides how that is so. So first discussing, this is in concept, we already use this concept a lot with glycemic control, the area under the curve. So it is the time in which your body is exposed to high LDL levels, the time of exposure also matters. Similarly, when you control your LDL, the time that you remain in the control also matters. So with every the magnitude of LDL lowering is important. Also, the chronological, that risk increases as and when you stay for the longer period of time. So if you see approximately and reduction by say 80 milligrams per deciliter for 40 years would almost translate into an 80% reduction of cardiovascular event risks. Again, in the stroke target, treat stroke to the target trial, it was seen that in patients who were maintained within low LDL cholesterol of less than 70, they had almost 25% reduction in repeat cerebral vascular event, and again there was less, almost similar, 26% reduction in recurrent cerebral infarction and urgent carotid revascularization, and also the bleeding risk actually went down. So there was no extra bleeding risk as speculated sometimes. In the IMPROVE-IT study, there were in fact almost 6% patients, around 1,000 patients who had an LDL levels of less than 30 milligrams per deciliter within 1 month after the index event. And what this translated to, when this subgroup was actually carried and analyzed, it was realized that they had 20% lower risk of cardiovascular event as compared to those who had a level more than 70. So we see the Fourier family of trials. We have seen a lot of data with evolocumab and the other PCSK9 inhibitors, and in this trial, almost 25% patients had LDL of less than 20 milligrams per deciliter, and 40% had somewhere between 20 to 40, still maintaining the efficacy without any major adverse events. So this is a testimony to the fact that low LDL levels do not have major health risks. Again, the benefits are well established. We have seen lower is better. In fact, when you go down to less than 20, still at every decrease there is a separation in curve, and you have incremental benefit of lowering it further. So there are, in fact, this data with the Glasgow study, and there is, in fact, a trial underway with inclisiran now, which assesses plaque regression with LDL control, and all of these studies have shown a definite decrease in the plaque burden in patients who already have documented atherosclerotic plaque in their coronaries. So maintaining a steady LDL level actually helps in plaque regression. So how does this translate into guidelines? This is a very interesting chart, and this actually shows the journey of the LDL targets. So in 2011, as we know that targets were less than 100, and for very high risk population who have multiple events, the target was less than 70. Then in 2013, this concept of around 50% reduction of LDL crept in. But at this stage, again, the concept was to achieve a theoretical target number or a 50% reduction. Please, I would reiterate, it was or. Again, in 2016, the targets were slightly modified to less than 70% or a 50% decrease in if the LDL was in the range of 70 to 135. And it was almost in 2019 that the guidelines actually shifted from or to and. So the target was still less than, for high risk it was reduced to 70, and for very high risk to 55, along with, instead of or, then it shifted to and a 50, at least a 50% decrease. So both are important, and both, so when on the index event, it is important to have this lipid analysis and identify a target for that particular patient, which needs to be probably documented, so that there is an objective target that the patients have in mind, and as we as physicians also have in our mind. So with the most recent guidelines from both ESC and ACC are now in 23 and 24, and more importantly, our own Indian Lipid Association of India guidelines says that for very high risk population, the target should be less than 50. For extremely high risk or patients who have repeated events despite LDL control, in fact, the association recommends a target of less than 30 milligram per deciliter, and this is all while documenting and properly analyzing the safety of low LDL targets. So this is a chart from the Lipid Association of India. They classify patients as low risk, moderate risk, high risk, very high risk, and extreme risk. And the LDL goals are defined based on the risk targets. So the risk assessment is done by if there are features of major atherosclerotic vascular disease like age, smoking, tobacco, high blood pressure, and low HDL levels. There can be high risk features which are probably risk modifier, and there can be risk modifiers. So all this in the continuity and in a comprehensive nature is used to define a patient as one of the risk categories, and then based on the risk categories, we assign them the targets for LDL reduction. And what I have seen in our practice, this helps us once you give them an objective target, and you explain it to patient, they sort of, the compliance for the therapy increases much fold, because they have a tangible number which they try and achieve and maintain. So again, as pointed out, the recent ESC and the ACC updates all have now recommended a target of less than 55 milligram per deciliter for patients who have increased risk of ischemic or atherosclerotic events. Again, this is a nice chart which actually approaches. So we know the targets and how do we go about it. So this, I think this talk about the patient should be on statins and add-on, I think that's a talk of past. Most of the international guidelines now actually assume that you are already there on high intensity statins. So that's not up for discussion. So all these agents are not in, as a replacement of statins. So that statin is a part of your baseline therapy. So this is an important point which needs to be highlighted, that we need to do more about statins, but statins, high dose, there is no question about high density statins being a part of that particular therapy. So once you achieve those high intensity statins, you need to stick to your targets and try and achieve the targets with the other agents possible. So again, as iterated in the ODC studies, so we see there was no new insight from, like, we have a large family of trials now with various PCSK9s and missense RNA inhibitors, and we saw there is no new onset diabetes, no neurocognitive declines, no increase in the incidence of hemorrhagic stroke. So all the speculations about very low LDL level do not really have objective evidence which reiterates the claim, hence establishing the safety of low LDL levels, and we all know the benefits of it, and it's a good time to actually address. You can see the amount of molecules which are currently available or being evaluated for lipid control are enormous, and there is no reason for us to actually shy away from achieving our targets. Thank you. So just